Welcome, everyone. My name is Zach Miller with Landmark Ventures, host of the Social Innovation Summit. The Social Innovation Summit is a platform designed to elevate groundbreaking ideas and innovative leaders who are making a difference in changing the world for the better. As part of the Social Innovation Summit's annual events, we are honored to partner with leading organizations to amplify conversations and solutions around the biggest issues facing the world today. Throughout the summer, we're teaming up with AARP on a digital event series to talk with national leaders about issues that impact longer and healthier lives for all communities. We have all seen that the COVID-19 pandemic has further exposed inequalities that have long existed. And critically in this moment in America, we are seeing these issues rise to the surface. Although disheartening and absolutely frustrating, it gives us the opportunity to seize the moment to rebuild our communities to serve everyone equally, to help us ensure that everyone is able to live longer and healthier lives. And that's what this series is all about. Today, we're excited to welcome Dr. Richard Besser, President and CEO of the Robert Wood Johnson Foundation, who will dive into a conversation with Lisa Marsh Ryerson, President of the AARP Foundation, on how to address America's most critical health challenges. This solutions-oriented conversation will explore strategies and approaches for advancing a culture of health that will positively impact longevity outcomes for all communities, particularly our most vulnerable. We've sent all attendees a digital brochure with the agenda and speaker bios for today, so please give that a look. And we're taking questions from the audience that our speakers will engage towards the end of the discussion. So please, we encourage you, submit those questions throughout the event so our speakers can answer them, and you can submit those through the Zoom Q&A function. And now, without further ado, to get our program started, I'm pleased to welcome the President of the AARP Foundation, Lisa Marsh Ryerson.
Zach, thank you for that great introduction, and I join you in a warm welcome to all who are joining us today for AARP's ongoing series on equity, where we engage some of our nation's leading thinkers, like Dr. Rich Besser, on big ideas and on forward-thinking solutions for recovering from the COVID-19 pandemic and for rebuilding, but rebuilding with stronger communities. We're very excited to host Dr. Besser, who is a leading public health expert and the President and Chief Executive Officer of the Robert Wood Johnson Foundation, which I'm sure many of you know is one of the nation's top public health organizations. The work of RWJF is closely aligned with the work and mission at AARP Foundation, where we work to end senior poverty by helping vulnerable older adults build economic opportunity and critical social connections. Our work is bolstered by vigorous legal advocacy as we spark bold, innovative solutions that foster resilience, strengthen communities, and restore hope. And one of the most pressing challenges facing us today is health inequity. The Robert Wood Johnson Foundation has been a national leader, a leader in constructing a lexicon that your zip code should not be your destiny. Over the past decade, they have led the development of a wholesome and robust body of research examining the causes for these disparities in longevity. And as you'll hear from Rich today, this approach is creating a culture of health. And the culture of health work mirrors Dr. Besser's life work and his commitments. As Zach said, unfortunately, over the past several months, we've seen these health inequities through the lens of the coronavirus pandemic. They've been brought into higher relief. And in the United States, COVID-19 has disproportionately affected communities where historically there has been little opportunity. Blacks and Latinos have been hospitalized and are dying at disproportionately higher rates. These disparities, we know, are not random, but instead are the result of a long history of inequality due to a lack of social, economic, and political opportunity. And that's why I'm so pleased to be here today virtually with a wonderful colleague of AARP Foundation and AARP, Dr. Rich Besser, to talk about solutions to these questions and to much more. For many years, AARP Foundation, AARP, and the Robert Wood Johnson Foundation have worked together to center equity into healthcare practice and also into policy. In fact, RWJF has worked closely with us to advance health equity and improve access to high quality care by building a more highly educated and a more diverse nursing workforce through work led by my great colleague Susan Reinhardt at the Center to Champion Nursing in America and the Campaign for Action. So I cannot think of a better thought leader, a better person to discuss how we move forward in making sure we emerge from this crisis, from these converging crises, better, with more opportunity for those people who are traditionally left behind to live healthier, more productive lives. I'm really delighted now to welcome my colleague, Dr. Rich Besser. Rich, it's great to have you joining me today for this important conversation, and one that I've been looking forward to. And I begin by saying it's always such a delight, and of late I've seen you in a variety of different forums speak about the important work that has been your core commitment across your life. But maybe the best place to start for you and for me is if you would talk more about the important work that Robert Wood Johnson Foundation is doing under your leadership to really dig into community response to COVID-19. And I know you've been looking, in fact, at 9 very diverse communities. So if you would frame that work and tell us a bit more about what you're learning about what's working.
Thanks so much, Lisa. It's really an honor and a pleasure to be here with you to talk about these issues. We really view AARP and the AARP Foundation as important partners. You know, as you laid out in your introduction, the COVID pandemic is shining a bright light on so many inequities in our society. When you look at how this has been playing out across the country and what groups have been hit the hardest, clearly every community is being hit by COVID and every life is affected. But Black, Latino, Native Americans are being hit disproportionately. And people in low-income communities being hit disproportionately, and we'll dive into many of the reasons for why that's happening. But one of the real challenges that there is getting good insights in terms of what we call in the emergency response world situational awareness. What is actually happening on the ground? And for many of the issues that we're looking at, the ability to truly identify which populations are at greatest risk, who is getting hit the hardest, isn't because we have the data being collected proactively. It's coming from research studies. And one of the things we do at the foundation is support research. So as you mentioned, there are communities around the country that we have been tracking for a long period of time that we hope will be able to shine a light on the impact of this pandemic and what has worked, in particular what works. Because as you said, it's not just about collecting data so you can report and say, you know, these are the groups that have got hit the hardest. When we look back at the pandemic, it's data for action. And the data for action part is if you identify what a barrier is, what can you do either through the public health system or through policy change to ensure that those barriers are removed and everybody has that fair opportunity to protect their health, the health of their families and communities.
Yeah, I think you're so right, Rich, because as you said, it's not that we don't want more data. And as you frame it, situational data and more information or evidence is better, but we have to be able to move to action. So I think the work of RWJF over time and really building a culture of health and finding out what those barriers are, it's about addressing social determinants of health, you know, more important now than ever. And as you were talking again about those hardest hit, it really relates to our topic today because it's about those who are older. So it shows this buildup of inequality over the course of someone's life. I want to dig in a little bit more and have you talk about so much of your work has been lifting up the connection between systemic inequities or structural racism and health outcomes over time. So if you would really talk about that from the perspective of your lifetime of work, and how does it affect not only individuals or communities, but what about these leading indicators? I mean, our nation actually is not at the top of the list for positive outcomes. So if you address that.
Yeah. So I'm speaking to you right now from Princeton, New Jersey. It's
Right.
where our foundation's located. It's where I grew up. It's a predominantly white community, and life expectancy at birth here in Princeton is 87 years. I'm a general pediatrician, and I still work as a volunteer pediatrician in Trenton, New Jersey, which is in the same county as Princeton. It's our state capital. It's 14 miles away. Well, a child born near that clinic has a life expectancy of 73 years. So that's 14 miles away, a 14-year difference in life expectancy. And you can say, wow, if people in Trenton would just make healthier choices in their lives, that would go away. And it's like, that sounds ridiculous, because it is absolutely ridiculous.
Yes.
What that difference in life expectancy points to is issues of structural racism, differences in opportunity in terms of being able to lead a healthy life. If you look at the history of Trenton, you see a history of underinvestment. If
Yes.
you look at the history of New Jersey, just like the history of every state in America, you see structural barriers having been put up to mobility, so that we end up as a nation incredibly segregated. And with that segregation comes segregation from opportunity for jobs, for high quality schools, for safe places to play, for access to healthy food. And the data looking at upward mobility support that. It supports the differences in terms of mobility by race, by place, by income. And so once you move from a framework that one's health is solely about their choices, and how many times as a public health person, pediatrician, I've said, well, eat right, exercise, get a good night's sleep, get all your shots on time.
Sure.
If you move away from that and saying, yes, choices matter, it's important to make healthy choices, but let's talk about the choices people have, because the choices people make depend on the choices that they have. And for millions of people in America, they don't have the healthy choice.
Yeah, I think it's so important the way you're addressing this, because with our shared work and really creating more opportunity for all, and specifically with the work we're engaged in and ending senior poverty, we see poverty not as an individual failing. And that's what you're talking about. This is really about a societal illness and a national, it's about national accountability. But it's so striking to me, Rich, when you talk about 14 years and 14 miles.
Yeah.
I want people to really remember that as we're talking about building equity. And also, you're of course doing the right thing, reminding all of us about what we need to do to optimize longevity and health. But I think it's critically important. And when Wes Moore was talking with my colleague Jean, and when the mayor of Stockton, California was talking with my colleague Stacy, they also talked about this issue of choice. You're reminding us that it has to be contextualized.
That's right.
That as it turns out, and what you and I know and others know, individuals make good, rational choices given the options that they have.
Right.
And so our work together is really building that base. How do we address the social determinants of health, whether it's education or safe and affordable housing or food security, right?
Yeah.
Income. What are you seeing in terms of it? I've been struck, and you've invested a lot and you've talked a lot about our frontline healthcare workers and the heroes across many disciplines or sectors in the COVID-19 pandemic. There are families, I know in our work at the foundation, who are having to make this really tough choice between the collective health of their family and their economic security, getting to work. So do you have anything more you can add to that in terms of what you're seeing, or what you think we need to address from a policy standpoint nationally?
Well, this is one of those critical factors when I was saying earlier that the differences in impact by race and ethnicity in America, and who in America has the opportunity and choice to stay at home, work remotely, only go out for essentials to buy food.
We do, right?
Yeah, I do. I'm sitting here exactly a position of privilege. I can do that. And, while it's inconvenient to me to not be able to work with my colleagues in the building, it's not a life or death decision for me. For millions of people in America, they're forced to make a choice between going out and working so they can put food on the table, they can pay the rent, or staying home so they can protect their family and their community. And you mentioned frontline healthcare workers, and there's been, and rightfully so much conversation about the needs of frontline healthcare workers, the need for personal protective equipment. But the conversation, especially early on, failed to acknowledge the other essential workers.
I know.
Those who are working in meat processing and poultry,
grocery stores.
Plants, those in grocery stores, those running our transportation systems, those who are other first responders, those who are working in people's homes as home healthcare workers, for those with disabilities, or for the elderly. And there hasn't been enough attention in terms of what are their needs in terms of personal protective equipment. How do we make sure that they are considered heroes as well? I heard someone use the phrase, we talk about them as essential workers, but in reality, we treat them as expendable workers.
Yes.
Because we don't pay even a living wage for many of these jobs. There's truly no free choice in terms of whether people go to work. And when someone gets infected on the job in one of these occupations, they're often sent home to households where they may be living with an elderly relative who's at
That's right. Or multi-generational homes, right?
Exactly. Much more likely to live in multi-generational homes.
Oh, you're so right, Richard. And, for the population we're working with at AARP and AARP Foundation, this is 50 and older. We have a number in our workforce programs of older adults, 50 and older and well beyond 50, who are those essential workers who are headed to the grocery stores or working in public transportation or any number of other jobs where they are not receiving what I would say are family sustaining wages. And so, it is this issue of economic disparity, right?
Yeah.
Income disparity, and the fact that they are older adults really who have much higher risk. And
when
because of healthcare.
If you compare across countries and look and see what the trajectory for COVID has been across Europe, across many Asian countries, some African countries, Australia, New Zealand, what you see is a safety net that is very, very different from what we have here in the United States, where if people aren't working, they're not losing their jobs, they're still getting income, where people have health insurance. Here in America, we have a situation where a quarter of U.S. workers don't have sick leave or family medical leave. And if you look at low-income workers, it's close to 50%.
Yes, that's right.
And then, when it comes to unemployment insurance, if you're a worker who's cobbling it together by working 2, 3, 4, minimum wage jobs, you're not going to be eligible in a lot of states for unemployment insurance. And so, the choice that people have is really no choice at all. It's a choice that breaks down along class, it breaks down on geography, it breaks down on race and ethnicity. And if we can recognize that and agree across the board as Americans that everyone should have an opportunity for health. We talk about this as a land of opportunity. What does that mean? What would that really look like if we truly wanted to implement that? It doesn't look like what we have now.
It doesn't look like what we have now. It goes back to how you opened, which is it's about that situational analysis coupled with the context. And also, how do we, this is about collective humanity, right? Our shared humanity. That's the conversation that we're in today. And really moving beyond the dialogue. You think about the convergence of all of these pandemics, of COVID-19, of racism and long-time discrimination, of economic downturn, and we have to take action now. In fact, I'm struck by an opinion piece that you wrote in the Washington Post recently about this, that these inequities, they're in high relief now, we're in an inflection point, but they have been stalking us nationally for a long time. So I was really sort of driven and inspired by that piece that you wrote, and your call to action around that. So anything else you're seeing that is working in communities? I know it's about embracing the reality, but it's about investment, isn't it?
It is.
So we have to decide that we will invest in our health systems, and that we will allow health systems and healthcare at all definitions to do the work of addressing social determinants of health. And to be expending resources and developing, in my mind, closed loop systems, so that when you're doing more than a warm handoff to a community-based organization who can step in, and that requires multi-sectorial work at a whole new level.
Mm-hmm.
Where have you seen that working, or how?
Well, there are a number of pieces I think to unpack there. One is, health is about far more than healthcare.
It is.
But healthcare is an important piece. And at the start of this pandemic, there were 28 million people in America without health insurance, and many millions more who were underinsured. And working Americans paying more and more each year for their premiums and for their deductibles. But the way that has played out in the pandemic is, if you look at a lot of the guidance that CDC put out early on, they said, if you think you have COVID, don't go to the emergency room, call your doctor, because you may be able to manage this at home.
But what about the fact that people don't have primary care physicians?
Exactly. So if you don't have a doctor, what are you going to do? You're going to probably wait and go in late, which can affect the outcome of your illness, or you go to the emergency room, and if you didn't have COVID before, you may pick it up while you're there. So we have to decide as a nation that having health insurance is a right, that everyone should have access to fair, comprehensive, high quality health insurance. And there are many ways to get there, and that can divide along partisan lines. But if we all agree that that should be a right, then that gets us going in the right direction. But if we see it as something that, no, it's a perk from having a job, which is really just that's a quirk of World War II in terms of how our employer-based health system came about. We have to get away from that mindset and view it as something that everyone should have a right to.
Yeah. And it's a myth, right? Not every job does come with the benefits, as you and I know, and my great colleagues at AARP, recent research shows that as it relates to the population we focus on, 50 and older, unemployment is high right now, and well over 30% have reported that they've lost their job because of a workplace closure, or they've fallen into underemployment, meaning they're in part-time work.
Well,
and they don't have access to benefits.
Yeah, we're seeing communities coming together to address issues of healthcare, but also address the issues of what's taking place in communities. And we give out prizes every year. We call them our Culture of Health prizes. And a couple of years ago, I had the opportunity to go out to Kansas, to Allen County in Kansas.
Yes.
And saw this rural community that had decided to come together. Unemployment was up. It was a situation of disinvestment. Come together to say, we're either going to go away. We're not providing opportunity for young people. They're all leaving, or we're going to come together and we're going to fix this. And one of the things they did, was say, we've lost our hospital, and without a hospital, it's very hard for us to stay here because there's no health care. And it's something we're seeing across rural America. Well, they agreed to an increase in their sales tax in order to fund the building of a new hospital. And they came together around that and said, no, this is important. We're going to do this. Yes. They'd lost their only supermarket. And so as a community, they came together and they approached a supermarket chain and made the case for why Allen County was the place to build a supermarket. And they got one. And there was a sense of pride of coming together to solve this. And what I like about it is community identifying what needs to happen and doing it. But there's a bit of a myth that you can lift yourself up by your bootstraps. And you have to say that as a total solution isn't going to work. We have to look at how we're investing and not investing, as a government, where government dollars are going, and address that from a policy perspective, so that we're seeing investment, broad investment across income groups, in urban areas and rural areas across America.
Yeah, I agree with you, Rich, and I always enjoy reading about the culture of health winners and the great work that communities are doing, because you're right, it really is collective impact work. And it's both at the individual level and across, multiple sectors. And once you agree on that shared goal, there are gives and there are takes across those solutions. So you and I know that we can and must do better. But it is, in my mind, about, just as the town and community in Kansas, it's agreeing that we actually want equitable outcomes, that we do not want race to be a barrier for having the same outcome. And as I hear you talk with me today, I'm reminded that that often means there will need to be disproportionate effort and investment to reach equitable outcomes. But, you know, these pandemics, we have to do better. We just have to.
Yeah, one of the things that we've done as a foundation is we developed equitable principles for state and local officials on how to restart and how to address. I serve on the New Jersey State Commission and on the 7 State Regional Commission, and we spend a lot of time talking about equity.
Yes.
And equity doesn't mean every part of the state gets the same. It's
That's
about
right.
every part of the state getting what they need.
Yes.
And there needs to be that reflection on that. And in places where there have been historic and ongoing barriers due to racism, that has to be addressed with investment and with a different approach. And I'm glad to see it be part of the conversation. It's really important that we hold our government leaders accountable for addressing things in that way. And there's a lot more that needs to be done if we truly believe that everyone should have a fair opportunity to protect their health and the health of their communities.
Yeah, and what I'm appreciating about our conversation is that you're lifting up examples of where it's working. And so we do have some best practices that really need to be embraced much more broadly nationwide. Equally important that we recognize the action does require smart policies. Right. As the foundation, yeah. And that we recognize at every level that budgets are really statements of values.
Yeah.
And so
one of the ways that the statement of value is playing out right now is around the conversations around school reopening.
It is.
Because if you look at what we say about value, it comes through loud and clear in terms of how we fund schools in America. Schools across America, in many places, are largely funded off of property taxes.
Yes.
And so what that's saying is in wealthier communities, largely white communities, we're going to see much higher quality schools. And in lower income communities, serving more Black and brown children, we're going to see lower quality. And so, you know, even now, as there's efforts to restart school and get children back into school, well, which children are going to be able to get to school? Which ones
with the
not?
Right resources, right?
Exactly,
with the right resources.
In a safe way. And which teachers and which staff are going to be at increased risk? You know, it says a lot about our values as a society.
It sure does.
Where you live and the color of your skin may predict how you do during this crisis.
Yes. And, you know, we were at it. You may know that at AARP Foundation, we run Experience Corps, which is an intergenerational, we're in the most underserved schools, where our volunteers who are 50 and older of community are literacy tutors to really try to break that cycle of poverty in communities. So we see this in high relief right now, but of course we're working round the clock to be sure that our literacy tutors have the digital tools that they need to still connect with the learners and help the teachers. But those inequities are deeply embedded, and we have to continue through the great work that you're leading at Robert Wood Johnson Foundation, the work that so many organizations are engaged in, to come together and build a better future. Well, I had tons of questions about your book and about your mentors, but this has been so engaging. I'm going to call to the stage my great colleague, Ian Hartman O'Connell, who is going to help us with our Q&A. Ian, welcome.
Terrific. Thank you, Lisa. I appreciate it. And it's great to meet you, Dr. Besser. So one of the first questions that kind of touches upon what you just discussed, which is that people of color have been one of the hardest hit groups of coronavirus pandemic. And so if you had a magic wand, right, the wonderful magic wand, what would you do on the federal level to make sure that these communities are not only responding to this pandemic better, but better prepared for the next event or similar situation?
Well, I think there are a number of things that have to happen right now. One of the things that gave me hope in this pandemic was when Congress came together early on and provided through the CARES Act relief to people, put money in people's pockets, put up a federal moratorium on foreclosures and evictions and for utilities being shut off. Those were important steps, but they were not permanent steps. They were time limited. And this pandemic is going to go on for a long time. You know, it will go on for at least another year, probably much longer than that. And putting money in people's pockets one time as unemployment is rising and rising isn't enough. The supplemental unemployment benefits that people got have expired. And we know that those benefits allowed many people to pay their rent. And we know that as eviction protection is going away, that there are tens of millions of people who are at risk of eviction. And as bad as this pandemic is, imagine this pandemic if you were homeless, and what that means to be out without a roof over your head, a safe place to be. So
well, and the storms,
yeah,
bring that to the fore.
Yeah. In terms of short term, those are things that Congress can come together to fix. For longer term, there are a number of policy changes that have to take place. We need to ensure that everyone has health care. So some form of universal health care is absolutely required. You can start to get there. There are 12 states that didn't expand Medicaid, and that affects older Americans in a major way. That affects lower income Americans in a major way, people with disabilities. So, those 12 states could expand Medicaid, and that would be a terrific thing. We're the only wealthy nation that doesn't have uniform sick leave and family medical leave policies, that doesn't have broader based unemployment insurance. These are things that need to change, and we need to make sure that eviction is not something that is so disproportionately a crisis for people of color, for the lowest income Americans who at a much higher percentage pay 50% or more of their income on rent. There's a lot that can be done. We just have to decide that's what we want to do. And we have the resources to do it. It's a matter of choices as to where we spend our money, whose lives we put value on, and whose lives we don't.
You certainly know from your work, both in your medical career and at RWJF, that housing is the linchpin of well-being.
Yeah.
So I so appreciate that you're calling out the importance of stopping these cycles of eviction.
Well, the issue about housing that I think so many people don't recognize is how structural racism is built in to housing in America and who owns a house. In the large periods where the middle class was built in America following World War II, Black Americans were excluded from that.
Yes.
They weren't getting housing loans. They weren't allowed to move into neighborhoods in suburbia. And it wasn't from a lack of desire. It was federal policy that prevented loans from going. And so the ability to accrue wealth that was so important, that so related to owning a house, was not something that was available to Black Americans. And
it's
part
as
of the
if
reasons you see a 10-to-1 differential in terms of wealth.
It's as if we think someone else created redlining.
Yes.
Right,
exactly.
as opposed to the shared accountability there.
Yeah.
So if you don't mind, I'm going to transition based on the kind of the wealthy nation insight. And what do you think one of our attendees asked, how does the U.S. learn from other countries and what they may be doing, investing in preventive mechanisms to address aging, also how they're responding to the coronavirus pandemic? Are there things that you've seen around the world that you think we could bring home here to the United States?
Yeah, that's a terrific question. We have a program at the foundation, Global Solutions to U.S. Problems, and what it's all about is it's recognizing that solutions to the world's problems don't know borders, and there's no monopoly on those among wealthy Western nations. And so, looking to see, there are models in terms of one of the critical things we're seeing now, and seeing in a big way among older Americans, is isolation.
That's right.
And the mental health impact of this crisis. And there's a lot we can learn from other countries in terms of connectivity, connection. How do you maintain social connection while you need to physically distance? And there are ways to do that. And I know it's a really important issue for AARP.
It is, and in fact, I'm excited to hear from members of your team who are just launching a lot of the work that you've been investing in a study. But as you might remember, we invested in a comprehensive study for healthcare as a solution with the National Academy of Sciences, Engineering, and Medicine. And it's growing during this time. 25% of older adults were isolated before we knew the word coronavirus, and over 40% were lonely. Yeah,
and in terms of the overall approach, we're seeing country after country around the world getting this pandemic under control. The biggest outlier on that is the United States. And it's not because the solutions won't work here. It's because of the incredible disconnect between political leadership and public health science. And so rather than leading with public health science and having a uniformed approach to wearing masks and social distancing and ensuring people have the resources they need to take care of themselves and their families and to isolate and quarantine. We have mixed messages coming from the top that there's nothing to worry about, that wearing a mask is a choice, that who knows if it works anyway. And whenever you see that, I ran emergency preparedness and response at CDC for 4 years. And I led the agency at the start of the H1N1 pandemic. And one of the critical success factors in any public health response is if you can keep politics out of it.
Right.
Because if you can unify as a nation and come together and recognize that viruses don't care what political party you belong to, and the approach to preventing them doesn't care what political party you belong to. If you come together that way, then you can make real progress. And we can do that. We haven't done it as a nation so far, but that doesn't mean that going forward we can't turn this around and really see a dramatic decline in the impact of this pandemic.
Yeah.
So another question came in, and I think, we've heard the great work of the AARP Foundation, the great work of the Robert Wood Johnson Foundation, but we really can't go it alone in building a culture of health. And so, Rich, how do you work with other funders, other system builders to kind of build this culture of health across the country, and how do you kind of collaborate with them?
Yeah. I mean, we work with a lot of different funders in many different areas. I'm really proud to co-chair a philanthropy group on disability, the President's Council on Disability Inclusion, that's looking to see how can we, in our grant making, in the work that we do, be more inclusive of people with disabilities. It's been an area that a lot of us have fallen short, and we need to do more to make sure that in all our grant making, we're being inclusive of everybody. One of the exciting approaches we take at the foundation, though, is around leadership and supporting leadership development across sectors. We have 4 very large leadership programs that look to help build the capacity within communities for people to address the problems that they see. And it's not that they lack solutions, because people closest to problems will be more likely to have solutions to those problems than we will. But it's helping them with agency, helping increase community power so they can affect change to those problems. And that kind of leadership development and networking, I think, is a really important approach. And the work that we're doing with AARP around nursing, and nursing engaging around equity, and seeing the role of nursing as a broad participant in communities, is incredibly exciting and is a critical piece of solving this problem.
Yeah, we agree. It's exciting. It really is. Nurses as leaders, right? And really empowering them in their practice. And I know that the Center to Champion Nursing, with your support and partnership, has been working so closely with the foundation, Rich, on addressing social determinants of health and really looking at how we expand across healthcare. To your question, Ian, or the audience question, I think, Rich, what's been so, among other powerful thoughts and ideas that you've shared today, is this concept of we have to work with community. If you ask people what they need, what are the barriers, they will tell you. And so we cannot, as a group of organizations, sit and come up with great ideas in search of problems to solve. So it really is that the best of human-centered design and helping to invest in communities and community leaders to get the work done.
Yeah, I think this moment with the anti-racism movement in America having such powerful voice really calls that out, that the solutions to issues such as structural racism are known, and letting people lead from where they are rather than a hierarchical leadership coming from institutions like ours, but a distributed form of leadership where people are leading who are closest to the problems, who have the solutions, helping provide resources so that their ideas can move forward, is going to get us to the place we want to go, much more than the model that we've traditionally used.
Yeah, I agree wholeheartedly. Ian, it looks like we have time for one more question.
You got it. So I want to build on the last one and talk about, so the healthcare space seems like a natural fit. And you mentioned kind of working with grocery stores. And so there's a number of questions about working with the private sector outside of the healthcare space, and how do you engage them, and how do you collaborate them? Are there concrete ways that you've done that through our WJF or in other points in your career?
Yeah, we've done work in terms of working with businesses on equity and understanding the concepts of equity and how that applies to business. What is the business case for more equitable development? Currently, the Business Roundtable is looking to see what can businesses do in this moment to build more racial equity into their organizations. And it comes from the clarion call that's happening around the nation that what currently is can no longer be allowed to be. And it's important. One of the things we look at is how do you evaluate businesses on their connection to community, to their ability to do social good, and how do you then spur investment in businesses that are supportive of that and helping to build an economy that isn't just doing well but is doing good at the same time. We have the power to do that through our own endowment and our own investments, but we also have the power to do that through funding tools that will allow others who are looking to invest to support businesses that are doing good.
Yeah, I think that's so terrific, and you've really been a leader in that space. And in essence, it really is the shared value model, and the question and what Rich is talking about. And it does require that commitment to bringing to having all of the sectors understand that they have a stake in getting this right. That building equity is certainly good for our shared humanity, but is great for their business outcomes as well. And it's tough work, but I think we're seeing more examples of this in communities across the nation. All right, Ian, time for us to wrap up unless there's one more burning question.
I think we've touched upon a lot of the themes that we've seen emerge, and Rich, we really appreciate the time today and engaging our audience for the past few minutes.
Thanks so much. It's a real pleasure.
Yeah, I just want to wrap up again, Rich, with a huge thank you to you. You bring such deep and broad experience, but again, what was evident to me today in our conversation is that this work is your core commitment. It has been your core commitment across your life as a physician and as a public health leader. And just know that we're very excited at AARP Foundation and AARP to be partnering with you as we address these issues. As you said today, the COVID-19 has touched so many individuals and communities and really brought to the fore structural racism and discrimination in our nation. Hard to find bright lights, but I think what you've helped us understand is there are some bright lights, which is that there are ways to do better. We can and we must do better. And there are examples in communities around this nation about what happens when we bring the right leaders, the right organizations, the right investments together in and with community. And when everyone does better, we actually all do better. So what a treat to have you as a colleague and a friend. And I know everyone listening today, and certainly my colleagues at AARP, join me in thanking you for your continued work. We need you in this on behalf of this nation. So thank you.
Thank you so much. It's been a real pleasure having the conversation and sharing. We really value the partnership with AARP and the AARP Foundation.
Yes, great. We want there to be a society where we all get to choose how we live as we age. So way past time to build that equity. Thanks, Rich, and thank you everyone for joining us today.